Hello, everyone. Thank you for joining our webinar this evening. I'm Heather Flannery. I'm happy that you've joined us. This is the DC Distributed Health webinar series focused at the intersection of blockchain and healthcare. Before we get started on tonight's exciting event focused on the intersections of financial and insurance tech with blockchain and healthcare, I'd like to address a couple of housekeeping matters regarding the event. First, everyone is on listen-only mode automatically. This keeps audio quality high and makes it so that everyone doesn't have to worry about muting. Next, in terms of the format of the event, I'm going to introduce our speaker momentarily. The speaker will then give a 15-minute presentation, and at that point, it will be followed by an interview format focused on the content of the presentation. During that time, we'll have asked you a couple of poll questions, and we appreciate it. As soon as 90% of the audience has responded to the poll, I then display the results and we can talk about them momentarily. And then we'll have about 20 to 30 minutes at the end of the session in order to do audience questions and answers. During that time and throughout the event, I highly encourage you to capture your questions in the question and answer dialog box in your GoToWebinar utility. That portion of the event will sound a lot like a radio show. I'll be taking questioners off of mute, having given you a heads up in advance. We'll then ask you to reiterate your question. You'll have some dialogue with our guest speaker and myself, and we'll put you back on mute and move to the next questioner. The last thing I'll mention is that the event will be recorded and redistributed, so we don't need to deal with that question. And I'm really excited to introduce Jim St. Clair. Incidentally, Jim, before you jump in, we're having a webcam technical difficulty this evening that Jim's working on, but he's here with us on audio, and we'll be delivering the presentation. Jim, would you like to introduce yourself?
Hello, this is Jim St. Clair, and yes, the beauties of working from your hotel room on a snow emergency night. Just moments before we got this going, at least we had it set up, but unfortunately, I believe I will be rather frozen on the screen for you, but I am here, and I am thrilled to be able to give the presentation. It is a thrill to be able to work with Heather on this. I am the Chief Technology Officer for a company called Dinocrates, and I am the founder for the Institute for Healthcare Financial Technology, which I have been in the process of getting off the ground now for a couple months. And as the tagline indicates, I'm specifically interested in what I call revolutionizing the healthcare transaction. And I'm very excited to have a chance to talk to you about it tonight.
Well, thank you, Jim. I think this is an absolutely vital area of value add for blockchain and distributed ledger technology in our health sector. And I'm looking forward to a really engaging discussion with you after your presentation. So before we get started with your presentation, we'd like to be able to understand a little bit more about our specific audience this evening and where everyone fits with respect to your current professional roles and healthcare payments. So if you don't mind, if you'd please, you should see the poll that has just popped up on your screen. You have 5 options to place yourself in context of healthcare payments. Perhaps you focus in this area as a payer, somewhere on the provider side, perhaps as a health IT practitioner, perhaps you're focused on value-based or alternative payment models, or maybe you're not presently focused on the payments problem, but looking forward to learning more this evening. So right now, we have 75% of you voted. Thank you so much. If we could get a couple of more responses, I'd really appreciate it. All right. Oh, okay. Thank you. Appreciate the responses. And now I'm going to share our results. So Jim, I know so that you know these results. So we have 6% of our audience who's focused on the payer side of payments. Another 6% focused on the provider side, 25% focused on the health IT side, none focused on value-based payments, and 63% who are not involved in payments in their professional role. So any quick first reactions to the way that distribution shook out? Jim?
There we go.
Uh-oh.
Can you hear me?
Oh, yes, we can. All right.
There we go.
That was a
All
great.
right. I think that distribution is very interesting because I think hopefully we'll get into some of the concepts that I'm espousing in taking this role. And I'll start right off by indicating my interest in establishing the Institute comes from a background working in digital health and health IT interoperability. And after both my professional perspective as well as my personal perspective, working with chronic care issues and chronic management and dealing with multiple hospitals and doctors, I felt that if things that were going on in the world of insurance technology and financial technology aren't brought to bear to be able to truly revolutionize the fundamental underpinnings of how a healthcare transaction works, and a lot of these things we're doing around health IT just aren't going to be brought to fulfillment.
Yeah, absolutely. I think the timing is excellent for the vision of your institute, and I'm sure the audience is going to really benefit from hearing about it. I'm going to go ahead and drop off webcam. I will show back up at the close of your presentation, and I leave it to you, Jim.
Fantastic. And while we're sorting out these technical issues, I'll just use the phrase next slide, which is a little pedantic, but that's kind of a manual intervention so that Heather will know to move forward. And I'm keeping in time with my own local version of the presentation so we can sort out these hotel wireless issues that I'm experiencing at the moment, for which I apologize. So just moving quickly to slide 2. Welcome. For this presentation, we're considered the business of healthcare and the potential impact of changes to the business model as a result of technology, with blockchain obviously being a key part of that. I offer a largely US-centric view, but the concepts can be applied globally. And in this particular case, I'm not sure whether or not everyone is necessarily US-based or if we have a mix. Several of these other presentations I have made, I know that the audience was mixed, and so I try to be respectful of the fact that there are, excuse me, that there are numerous countries that may be represented who don't follow the same healthcare model as the US. But it is from a US perspective, as I mentioned, because of my experience with it too. So next slide, please.
Mm-hmm.
So how do we get here? First, there's the ideas of socialized medicine versus socialized insurance. No surprise, there are things that oftentimes irritate me when I hear talk in the news about the ACA and discussions of changes in healthcare and healthcare reform. And oftentimes I hear politicians throw out socialized medicine versus socialized insurance and mixing up the terms. You know, within socialized medicine, as many of you may be aware, is actually the concept where you have central control or even government control of healthcare delivery. And insurance, of course, is embedded in that. So my ability in other countries to walk into a hospital, see a doctor, receive treatment with or without necessarily incurring any financial costs is because those models are all built around a government centralized system. Those are other models that have been used in the world that include some balance between the two. They may be socialized insurance, which is, of course, in the U.S. Medicare and Medicaid. In other countries, it's a model where insurance is delivered, but the healthcare itself may be privatized. And then lastly, you have other models where insurance companies might be private, but they have very strict regulations as to how they deliver health insurance as non-for-profits, et cetera. Nonetheless, out of all of this year's Commonwealth Fund, again, ranked the U.S. last on performance overall, or next to last in access, administrative efficiency, equity, and healthcare outcomes. And I bring these up because liars can figures and figures can lie, but at the same time, we seem to have political discussions and refuse to want to explore actual changes when numbers are in our face on an annual basis saying that our system is broken and needs changes in how we actually manage the transaction of healthcare. And notice in the slide so far, I haven't gotten any discussion so far about health IT or the actual clinical encounter or any proposed changes for how a doctor actually sees a patient, because that's not really the question or the argument in question here. Next slide, please. The state of the American market. Americans are, as a result of these challenges, abstaining from seeking care, which means at some point they'll seek care, oftentimes in an emergency case. There's a lack of strength of preventative care. Preventative care is played down and in some cases even discouraged in terms of the financial market supporting it. There is opacity or almost obfuscation of market pricing, which I think probably represents maybe one of the biggest issues within healthcare delivery that is currently not addressed at all. You find convenient ways to blame an insurance payer for problems associated with a payer scenario of a claim being denied or a procedure not being pre-authorized. But if you start exploring the fact that one hospital charges $500 for a prosthetic that literally across the street or down the street charges $150 or some comparable procedure, and those cities such as Chicago and New Orleans that have begun those studies, informally, I would add, through local media outlets, not on an informal basis, I think you find that the results in national and global advances in digital healthcare delivery is limited simply by the payment model itself. If U.S. healthcare was a financial institution, in my opinion, it's an institution that's outstanding at black swan events, but can't manage positive returns or simple daily volatility. And by that, I refer to the fact that I certainly, from what I have seen, would recommend many U.S. hospitals for top-tier care that I would argue you probably couldn't get any better anywhere else in the world, and that institutes such as Mayo and MD Anderson can be held up as models for extreme development or extreme instances around chronic care issues and improving patient outcomes for extreme sordid diseases. But yet at the same time, I find myself personally engaged with difficulties for just simple encounters on a daily basis with a primary care physician. So by comparison, it's difficult to be able to establish financial returns on day-to-day interactions, again, in that pricing model that no one seems to understand and is intentionally obfuscated. But we all point to U.S. healthcare for being the best in the world around specific instances of unique care delivery that only pertain to less than 1% of the population. There's no market data to predict trends, despite the efforts of the triple aim. Participants demand market parity, but refuse to reduce inefficiencies. And traders are prevented from a flight to value. Traders being patients and recipients of healthcare, unlike in other market scenarios where you acquire shares or participate in the strongest performers, aren't able to be given enough information to understand what those are and how to move to them, and are trapped within their environment. Next slide, please. The triple aim is something many of you may have heard of. It was launched by the Institute for Healthcare Improvement in 2007. It believes there's 3 critical objectives simultaneously that can potentially lead to better models for providing healthcare. First, it is improving the health of the defined population. Second, is to enhance the patient care experience, including quality and access and reliability of care. And then lastly, is to reduce or at least control the per capita cost of care, which feeds heavily into the first 2 bullets. Accomplishing the triple aim, there are some components of the system that include a focus on individuals and families, a redesign of primary care services and structures, population health management, and then the last 2, which I highlighted, a cost control platform and system integration and execution. And in the context of IHI, they're not referring just to digital health interoperability, FHIR messages, CCDA, health information exchange, but system integration and execution that leads to transparency of the healthcare transactions itself and helps commoditize service delivery to eliminate the cost obfuscation aspect that complicates the ability to deliver quality care. So in 2008, my colleague John Casillas established something called medical banking, which was how I first got involved in these concepts of the healthcare financial technology. The medical banking concept proposes the handling of such processes electronically by leveraging current banking systems. It integrates banking infrastructures and credit resources with healthcare administrative operations to reduce healthcare costs and ultimately increase patients' access to care. And while it hasn't been broadly or pervasively adopted, the principles of medical banking remain, and some institutions such as Wells Fargo and a few others that I've worked with actually still have medical banking practices. For purposes of discussion and not to be disparaging, as a first primitive step, the idea behind medical banking was to disassociate that financial aspects of the medical transaction from the provider and from the healthcare institution to be able to establish what for any of us in business is a basic line of credit, stability in our revenue, and be able to make financial predictions of success and performance metrics for improvements that are impossible under the current system, and do so leveraging financial institutions that have systems built to perform transactions in the first place, something that most healthcare institutions really don't have and shouldn't be expected to have in the first place. Medical banking utilizes bank IT, and know how to manage medical transactions using suitable for remittance payments, can initially reduce costs by $35 billion annually if an extensive system of integrated medical banking was used. And so the specialized services that are typically included in medical banking include cash management. Emerging service areas include things such as card processing, which tie into health savings accounts, financial savings accounts, and leveraging bank delivery systems to reach the non-digital community of providers who aren't necessarily engaged in large-scale EHRs and be able to provide them transaction support as well. Financial technology, or fintech, is an emerging financial services sector within the 21st century. The term originally applied to technologies at the back end that consume consumer and trade financial institutions. And the term is expanded to include any technology innovation in the financial sector that improves and innovates transactions in retail banking, to include investments in cryptocurrencies. There's a note there for Bright Talk. For anyone who ever goes to the Bright Talk presentations, it is absolutely full of fintech discussions, panel sessions, results from webinars, etc. And of course, heavily featured through all of that is the use of distributed ledger technology and blockchain. Next is the concept of insurtech, or insurance technologies. This refers to use of technology innovations designed to squeeze out savings and efficiency from the current healthcare industry model. And like fintech, insurtech is disruptive, technology-driven, and aims to change the traditional paradigm of service delivery. Also, once again, heavily driven by the use of blockchain and distributed ledger technology. Insurtech is expanded very rapidly of areas of property and casualty insurance, as well as using blockchain and distributed ledger for securing immutable transactions around property items and insurance, and is laying a foundation, in my opinion, that can be carried over into health insurance technology as well. So what is HealthFinTech? I coined the term as a combination and assimilation of these new financial technologies into healthcare revenue cycle management, specifically to disintermediate traditional revenue models with the result of improving care delivery. Like fintech and insurtech themselves, these new technologies and processes will improve the customer experience. They'll streamline payment cycles, they'll increase efficiency, and they'll affect competition, especially where competition doesn't currently exist due to artificial constraints. This is a key slide. You can see it's a very sophisticated graphic that I've spent a great deal of time to develop, but at least captures my mental mind map, which is the Venn diagram overlap of healthcare, insurtech, and fintech. And in that middle, as you can see listed, are things like artificial intelligence, abbreviated by AI, blockchain, distributed ledgers, ML, machine learning, tokenization, which also goes back into blockchain, remote process automation, and alternative payment concepts such as microfinance and micropayment. We sit at a point that things such as microfinance and micropayment can be leveraged immediately to deliver improved healthcare transactions for residents in Zambia and Namibia, and nothing against people in that fine country, but we can't be able to do it for North Carolina or Texas. Next slide, please. So how do I envision health fintech in action? You have payers and patients and providers leveraging personal health records, artificial intelligence, and telemedicine for increased longitudinal data and virtual encounters, tied together with a blockchain providing immutable records of healthcare encounters and transactions. The patient's relationships may be funded through provider-driven ICOs and token transactions, for an example being DentaCoin, which will leverage a tokenized cryptocurrency model for transactions between dentists, patients, other providers in the dental network. And that funding may be supported through microfinance and microloan services that I refer to that are essentially unknown or unused in this country, but are being done in an SMS-based transaction model in other countries within the developing world in particular. Pricing models become transparent. Services could be pooled from multiple providers in an exchange fashion, leveraging a cryptocurrency type exchange model, and you can close deals with providers and encounters. I don't think that there's any reason why, if I'm necessarily going to a physician with a well-defined care plan or care treatment around evidence-based medicine that may have been supported through virtual encounters, through AI, and through telemedicine, that I can't be able to find transparently what the best course of action and the most cost-effective treatment is, especially with an expectation at some point that you will begin to pay more and more for your own care, and the insurance payer will be disintermediated from the process. InsurTech uses AI and robotic process automation to streamline processes and increase increases efficiency, which creates a new insurance payer funding sort of model. And the net result is that costs and transactions become affordable and transparent. Healthcare services and outcomes are not constrained by pricing and obfuscation of pricing. So as a result, I sit here at the precipice of creating the Institute for Healthcare Financial Technology, which will be off and running here in the next couple of months. It's dedicating to improving that healthcare value chain to reduce costs and streamline access and delivery of healthcare. The vision of the Institute is to build upon the explosion of these innovations in fintech and insurtech that I've laid out for you, and healthcare technology, especially these concepts around AI and RPA, blockchain and distributed ledger, IoT, and the Internet of Medical Things, IoMT. And we seek to inform, engage, and mobilize new audiences and payers, providers, patients, policymakers to take actions and raise funds that support health business programs around the world, but of course, especially focused in demonstrating things here in the U.S. So what are we seeking to do, especially in the short term? Creating awareness through blogs, media, and social media content, which will be coming soon as my website and social media platform is developed. We'll be increasing advocacy through participation in events and more presentations such as this. So I thank Heather again for being instrumental in helping me get the message out. We will look to be involved with pilots, proofs of concepts, and new technology demonstrations, not as a technology provider ourselves, but as a new platform for awareness and understanding of new technology and technology demonstrations that others can learn from and potentially adopt. In the near future, we'll have a web-based content management website with social media to advise, inform, and to advocate. How can you get involved? While the website's still in development, you can sign up for advance notices right now at HealthFinTech.org. You can follow us on Twitter at HealthFinTech, and the membership model will be coming soon as well, and we'd welcome the chance to hear from you.
All right. Thank you, Jim.
Thank you, Heather.
Yep. So I have, just so that you know what's on the screen, I've popped back up. Any chance your webcam might have revived before we jump in?
I'm taking a look right now. I still have good audio connections.
Yeah.
I can see the screen and I can see you. I'm not sure now why my webcam isn't restarting, but otherwise I am engaged in the session.
Okay. Well, very good. If at any point you're able to get it to click on, more's the better. If not, we're nothing if not resourceful. Well, first of all, I'm just extremely excited about your vision for the Institute, and thank you for providing that introduction. Some of the first things I would like to jump into are, let me ask you kind of an open-ended question to get started. Thinking about artificial intelligence, machine learning, and robotic process automation, give me a little bit of color about your vision for how blockchain and distributed ledger from a convergence perspective will create value in the space that you've defined here as health fintech.
Sure, that's a wonderful question. And without naming companies that are actually involved in some of those processes, what I can say, or other industries, what I can say is that there are working cases now of RPA, robotic process automation, and AI engaged in changing transaction models that leverage the blockchain in order to provide the immutable records associated with the transactions taking place. And just to elaborate a little bit more, RPA as a term is something that many people may not be realized, and this is really a business process reengineering where large-scale manual tasks, let's take claims processing as a perfect example, are evaluated, and relatively simple technology that are technically called robots. They're not your Isaac Asimov sort of devices sitting in a chair typing, but are independent software agents that can follow rule sets very similar to smart contracts in an Ethereum-based blockchain that will take over those manually performed processes working within sets of predefined rules and essentially streamline the manual intervention involved and fully automate processes that have been requiring a great deal of manual work. To support that, those formerly manual, now automated transactions can generate records that can be retained in the blockchain. So you have the blockchain as your immutable source of truth for what transactions have been done within the robotic process automation. And of course, AI layers a new level of intelligence onto how those automated transactions take place and can add to and contribute to the blockchain as well to establish a record for why decisions were made. And specific to the HealthFinTech case, while there are growing numbers of examples of AI being applied to a healthcare encounter and actual care delivery, my interest here is much more around AI from the transaction standpoint, or maybe AI can be used in conjunction with RPA to develop new models or heuristics around recognizing patterns or trends around how certain delivery instances occur, how much delivery instances and encounters cost, how do we optimize or suggest optimization vis-a-vis the IBM Watson ads that take a look at your crop and say, hey, I've computed if you use 20% less water in this area around these seasonal times, you'll lower your cost of crops to market. There very well could be models for that in terms of population health management that haven't been extracted yet. But again, because they lack things like an immutable record of transactions through blockchain, as well as process automation that could be capturing those statistics and supported by AI, they're not fully recognized yet. That is happening in financial institutions, and it's happening in some large payment industries, and it's inevitable, I think, that it can be applied in some ways to healthcare.
Mm-hmm. So the concept of robotic process automation is, as to your point, one that is not familiar to everyone. I think everyone has at least a notional idea about what is meant by artificial intelligence, including the way we continue to move the goalpost. And every time we make an achievement, we redefine AI to no longer be inclusive of that function. But this notion of a software robot, for the audience, for anyone who's not familiar, what you're talking about is a piece of software that interacts with existing legacy systems infrastructure in a way that is exactly the way a human being would interact with it, which is why they call it a software robot. So it gets to this issue of data abstraction, and anyone who's been on a number of these webinars know that I constantly rant about the problems in healthcare with manually abstracting data from pictures of pieces of paper into some kind of UI. And then if you were to combine AI that could correctly attribute data, and then you could use a software robot under the RPA kind of paradigm, you're starting to get to the point where you could greatly speed up claims adjudication. And if you're persisting those things on a blockchain, you now have transparency, immutability, known provenance, and so on. The question I want to ask you, Jim, about all of that is that the interests of all the stakeholders are not aligned with respect to transparency. And I'm curious, what are your thoughts about the applications of distributed ledger technology among ecosystem actors who both of whom on the provider and the payer side tend to have things that they wish to obfuscate in order to maximize the benefits of their particular business model. What are your thoughts about how your institute could address that challenge?
Absolutely love that. And I would say a personal motivator has been watching fintech specifically, and how the traditional banking model, which essentially has remained the same within Western countries for hundreds of years, is literally getting disrupted in terms of the availability of monetary instruments through cryptocurrency, the ability to perform transactions online that historically were restricted to going to an institution, even mechanisms such as credit ratings, credit scoring, and loan provisioning are quote unquote under attack from new technologies that are seeking information that already exists or easily collected through the use of robotics, as you very well described, or simple artificial intelligence models to be able to make financial decisions. Even within Wall Street, the concepts of what they call quants, which is the use of quantitative data and quantitative data analysis now through AI and other machines, is rapidly changing how stocks transactions are performed. All of those have a way, in my opinion, of potentially penetrating the healthcare market. So when you talk about the number of players and actors at the moment who are intentionally obfuscating on the basis that their business model depends on it, I just see it to be almost impossible that business model wouldn't also change as these same technologies bleed over into the healthcare environment.
We just had an audio disruption come up. Jim, are you still there?
Yes. Can you hear me now?
Yes, I can. All right.
Okay. I'm sorry.
No problem. We had a little bit of feedback there.
Yeah. I'm sorry about that. Yeah. My webcam or my laptop decided to reconnect to the session after all the struggling I've been to try and be able to do it. So,
well, it's keeping things interesting. And if your webcam, oh, hey, everybody, meet Jim St. Clair. All right. I'm so pleased that that worked. That's great. Thank you.
There we go. Absolutely. And apologize for the minor disruption there. So if you consider that there's just no way that some of these underlying things that are being done for financial institutions won't necessarily bleed over into how healthcare is done. And a lot of it, of course, is driven by policy, but even more so an underlying culture. I get into debates with other friends and family about this. In some ways, we fundamentally have to change. And this is waxing poetic and philosophical and getting away from blockchain, but we have to change our expectations for how we receive care and what care should be at a much more basic level, to then be more receptive to new technology and ways of doing things. When I worked for HIMSS, and this is no slight against any healthcare provider or physician, but we used to talk about, with the changes in digital technology, why can't we look at a model that a well-driven AI engine or concept like a Watson someday, and certainly not necessarily immediately, but someday, can provide some percentage of clinical analysis that we consider to be acceptable, quote unquote, in partnership with a nurse practitioner, an RN, or a physician assistant, to address some percentage of overall care delivery that gets caught up in ERs and being attended to through physicians, that essentially could be addressed in a different way, and in doing so, generate a new transparency as to the cost model associated with that. I also think that with the rise of commercial clinics and the acquisition of healthcare delivery models through payers, and that sort of merger and integration will also lead to these other concepts too. If I could, I'd offer perhaps the downside of the dark side to it. I only say dark side for those that are afraid to embrace it, is going to be increased personal responsibility for individuals to assume management of their own care. We will have pharmaceuticals through AI and through IoT that will measure when you're taking prescriptions, when you should, so that perhaps your claim will be rejected if you go and seek care for complications to a condition that you fail to follow a pharmaceutical and pharmacological regimen that was supported. I think these are inevitable trade-offs, and there are ways that people can move forward with this new technology, particularly blockchain and particularly AI, that advances a cause and it isn't simply there to punish people.
So you're getting to a necessary outcome of patient self-sovereignty with respect to their data, which can be enabled by blockchain technologies in a way that has never been achieved historically. But you highlight that patients may not wish to have this responsibility and raise important medical ethical issues about the increase of transparency. So we've got this problem where payers don't benefit from increased transparency to claims adjudication processes, for example. Providers may not benefit based on any number of patient experience factors or the degree to which protocols are in alignment with certain evidence bases, and patients may not benefit from increased transparency when Internet of Medical Things data indicates they're non-compliant, and providers or payers may choose to restrict access to care or subsequent treatment, which raises enormous ethical considerations. If you're thinking about contributing to the body of policy with respect to those challenges, what are some of the early actions that you think the Institute might advocate or engage in order to advance these things without, so what we want are all the positive results without the negative fallout? What kind of policy measures, or do you have an example of a policy measure that might be near the top of your list that you could see the Institute approaching from an advocacy perspective?
Absolutely, and I haven't strongly formulated one, and I hesitate to just take on single payer, but certainly the standardization for I think value-based care is a great trend. I think the increased adoption of APM, advanced payment models, advanced payment model infrastructure is another great trend. A lot of that, while driven through policy from CMS as an example, is been adopted voluntarily or in accordance with regulatory timelines. They have a great deal of potential benefit beyond just CMS regulations. While Medicare continues to grow in its constituency and its percentage of contributions to the healthcare environment, I think you'll see more carryover as changes are made to Medicare policy that affect a larger and larger chunk of the population as time goes on. So in some ways, demographics will guide policy in that regards. And I certainly don't mean to suggest that I'm intentionally trying to suggest anything around tough ethical decisions, but it does touch upon a nerve with me to a certain extent, because I see in personal cases where care is perhaps intentionally, to give them the benefit of the doubt, unintentionally rationed because of simple restrictions around payment models, where if we're going to bump into or bump up against rationing of care in some fashion, unintentionally or even deliberately, and again obfuscated because we're refused to admit publicly in a policy forum that we don't have enough money in taxes to pay for all the money we need in Medicare or in the state level in Medicaid, then what kind of open trade-offs do you then start to make ethically? What is the lesser of two evils in some cases, and making those decisions in as informed format as possible based on all the information that's available. Instead, you have politicians, and not to be overly critical of our political process, but you've had machinations just in the course of the last year where decisions are made on almost a daily basis that, like butterflies' wings, are flapping and creating tsunamis across state policymakers as they try to decide within the next 3 to 5 years what to do about Medicaid because of simple manipulation and legislation that isn't supported through any sort of analysis to date or other sources of information to provide analytics and trends. So I think that was kind of a roundabout way of saying that, you know, these these ethical issues will come to bear in some format, and they will present themselves as political decisions, right or wrong. And the more that they can be done between payers and providers and the organizations within the healthcare ecosystem before given a chance to be tinkered with, perhaps derogatorily with policymakers, then so much the better. And I'd add, from what I have read, these are also decisions that are having to be made around the world. There's no perfect socialized medicine or socialized insurance model and single payer model used in any other country that isn't also dealing with changes in demographics, in their healthcare delivery, cost of healthcare delivery, and the sophistication and complications associated with that delivery, as well as changing revenue bases.
So as we look at three enormous groups of stakeholders who currently all have divergent incentives of patients, providers, and payers, I think if I could encapsulate some of the things you've said in the last few minutes, it sounds like you're suggesting that changes in patient demands, perhaps by being able to more simply access free market, transparent pricing and make informed decisions, for example, it sounds like you're suggesting that changes in the patient perspective and what the patient is demanding from their health transactions will be the driver that leads to the discomfiture and positive change in the provider and the payer community. Am I correctly understanding that that's kind of how you see this transformation happening, that it requires patient demand for change in order to affect as a first step, or do you see other earlier steps prior to changing patient perspective or demand curves, if you will?
That's a thought-provoking question, and I by no means would say it's not correct, but it actually forces me to kind of think about it introspectively for just a moment as part of the answer. I think the answer is certainly yes, that what you described in terms of patient demand helps drive that. And so if we look at some other models within our demographics about young people and now young doctors, young providers, and others that refuse to walk into an environment where they can't necessarily leverage an iPhone or an iPad because that's what they've done for all their life, but now faced with institutional constraints where culturally more than technologically speaking, it's just not done. So that will certainly be a driver from the bottom up from a patient demand perspective. But I also just think that populations have been guided in terms of how technology has impacted them. When it comes to the issue of ethics and the issues of changing delivery models and concerns about, or I should say, when it comes to ethics and changes in delivery models, there is always a concern about what percentage of the population is disaffected or essentially will be left behind. And of course, that's been complicated to the digital divide. I advocate that if nothing else, as a starting point, as I mentioned a couple of times now, what's going on in the developing world and the adoption of technology in the developing world has to be looked at as models that can be brought back. I think that we have allowed ourselves to be politically and philanthropically hamstrung over issues of the digital divide and disaffected populations without recognizing that there are problems that we ourselves are pouring money into, we as citizens and as governments as the U.S., into developing world to solve those same problems and not acknowledging how they could be brought back here. For instance, the degree of penetration of cell phones in the U.S., notwithstanding just smartphones and app use, but even simple SMS-based communications, just having a phone and sending a text. I would offer, and I'm afraid I didn't double check it for the presentation, but I know it's well over 70% now or more, and probably higher just based on how those statistics are gathered, that 70% of the population from a conservative aspect who could participate in nothing less than SMS-based transactions for other healthcare-related transactions, for other information, and participate as part of a blockchain for that healthcare transaction as well. And we don't yet know what 70% of an engaged participating population at the lowest common denominator of technical engagement could result in terms of changing how a healthcare transaction is performed and the sourcing behind it. Knowing that we're seeing that being done with SMA-based transactions and microfinancing in other developing countries right now. There has to be evidence coming out of that, or besides Bill Gates Foundation patting themselves on the back for the great job they're doing over there, leveraging that knowledge and bringing it back as statistical inferences to be able to apply for how we change customer behavior in healthcare here.
Yeah, it's really an interesting challenge. I've spent part of my career focused on engaging and activating beneficiaries of foreign aid in the developing world, and in a global health focus, and it's very it's challenging because in those environments you have scarcity that creates demand for services, and a de novo environment in which you can deliver a model where in developed health economies you have a completely different set of expectations. So microfinance and microinsurance scenarios that are so ripe and beautifully situated to use blockchain technology to advance them, it presumes a healthcare consumer who believes that they are going to pay out of pocket for a health service, as opposed to believe that their existing insurance instrument ought to cover all of their health transactions. So those fundamental expectations those are not as easy to transfer from one health economy to another. Go ahead.
Yeah, that stimulates me, because that excites me on another level, which is I walk into a provider's office and I challenge them to pay. So you're exactly right. Everything you said about the model for changing customer expectations and they're participating in the cost, sadly, is still something that that we in the U.S. have to work on, and would like to be able to use these models we talked about. What I find even more, quite frankly, maddening is if I walk in the door and talk to a provider and say, you know what, I don't have insurance, but I have a credit card and I have the capacity for pay for things, just like I bought the car out there, just like I pay for my mortgage every month, all through financial institutions that trust that I'm going to come up with the greenbacks to make this work. So I offer you, I want to come in and see you today because my knee is bothering me. I may need an x-ray, and I understand it to probably be a minor orthopedic incident that we could solve through over-the-counter medication or some sort of therapy. How much would that cost me? And they look at me blankly.
Can't tell you.
500, 5,000, give me something. Show me the book. If you read the book, Healing of America, the author has a shoulder injury. He is able to go into a French doctor who opens a book in front of him and says, yeah, okay, shoulder is fair, $2,500 US dollars. See you Tuesday and I'll have it done. Now, it doesn't make any difference about whether or not the quality of the surgery from the French orthopedic specialist is better than the US or less than the US. The simple model is that you could be able to understand transparency and upfront what you're invested to do. And maybe even the ability to then leave Dr. A and go to Dr. B and say, you know what, he quoted me $1,500. Where are you at for this? Well, I can do it for $750. Now, I know there'll be people in the audience who will roll their eyes about, backroom medicine and that sort of idea. But the simple ability to engage in that conversation, that we have created such a cultural barrier around paying for healthcare, but yet demanding its necessity and demanding its delivery, such that we can't even get a simple offer when someone says, I have financial resources at my disposal and I'm willing to negotiate with you to pay what you believe to be a fair rate to perform this transaction, of which both of us understand it. I'm not asking you a sophisticated endocrinological question that I can't necessarily understand how it is that the glands in my body aren't working. I have something I perceive as an issue that we can fix together. What should that cost? And no one is able to provide an answer. That has to be overcome going forward in the future in some way for us to make wise policy decisions about how care is covered.
So speaking of wise policy decisions and putting a really fine point on this issue, let's for the moment differentiate cost from price and look at how our incentives for transparency are different. For example, what payers want is transparency to costs, and they want to set the price, and they want to cap margin, and they want to do that. What providers want is to totally obfuscate costs and to be able to communicate pricing absent any costs, any actual cost buildup. Any insight as to how we might be able to use blockchain technology to obfuscate aspects of a pricing buildup that gets to price, or some things along those lines? I'm trying to think about practical policy interventions using blockchain technology that could deal with these really sticky issues that keep these things from manifesting because of the economic disincentives of the different actors. Thoughts on price versus
Absolutely.
cost?
That's a great question, and while I don't have a proofs of concept to substantiate it yet, I do think that if you consider a distributed ledger model, either permissioned or permissionless, so let's use a Bitcoin type model. So it's tokenized, it's anonymized. You can make transactions as partnered in agreed upon levels of trust. Those transactions in this case constitute healthcare activities. It may or may not have healthcare data residing on-chain or off-chain, but either way, it's part of the overall equation. The blockchain itself can still provide you in a secure fashion analysis for transactions that may help drive cost of transaction information and may allow you to do so in what we'd consider now a method that would require de-identification or anonymization. Well, the blockchain itself, through its tokenized model, may support that sort of anonymization, but you'd get enough information about participant A and participant B without full disclosure of HIPAA-based identities that you could do analysis that this transaction occurs involving these participants, of which it's known this participant or the institute where the blockchain resides is demonstrating these behaviors around these events that indicate cost or pricing information that can be brought out transactionally or transparency. There's some other models I know that are underway right now in terms of cost and negotiation within supply chain. And unfortunately, I was going to talk to a few other people before this call to get some more details on it. But if you think about just-in-time delivery and negotiation of prices for service delivery and factors that go into that a blockchain can apply from a smart contract and a logistics supply chain management standpoint, and then apply that to healthcare where maybe participants are known or not known, but the details of the supply chain transaction still take place and have rules behind them in the smart contract that adjust for or allow certain costs to be incurred and not allow other costs to be incurred.
Yeah, it's I really like where you're going with those ideas, and it makes me think about an experiment that could be run using distributed ledger technology. This is a purely hypothetical, but if you think about cost plus pricing, which is something that's been experimented with over time, but the problem is the under GAAP accounting standards, you do not have except in government contracting that enforces a very specific allocation, right? You do not have a uniform accounting method such that direct and indirect costs and fringe and so on would be allocated. But with the blockchain, using distributed ledger technology, theoretically, there are at least certain transactional underlying cost components that could be verified, cryptographically verified as having been incurred. And then there could be an open market that says, I'll deliver such and such a transaction for cost measured this way, in this very specific way, for costs plus 5 points, cost plus 6 points, cost plus 2 points. And you could enable transparency to underlying costs and allow providers to bid against certain margins where and that's a means of transaction hypothetically that could create a lot of variation and change in the way that we do things. What do you think about? Do you think there could be a cost plus model where actual cost buildups or components within specific episodes of acute care, for example, or certain chronic diseases? Do you think that could work?
I think it is. And first of all, I think you're extremely astute to recognize the differences in the government contracting side and the use of cost plus fixed fee and other things which have put a man on the moon, and the hindrances within the US GAAP model. But that being said, I had to turn for a second just to Google to pull it up because I was drawing a blank on the name, but I'll give a plug to an old colleague of mine, Jim Brimson, who pioneered activity-based costing. Activity-based costing is similar in concept to the cost plus model. It allows you to derive elements out of the activity to become the basis for recurrent costs. It can be encompassed entirely under GAAP and in the XBRL standards, and especially in IFRS, which there may be some movement towards anyways, and could potentially be derived as hash data elements within the blockchain, while at the same time anonymizing the parties involved in the transaction. Maybe that anonymization would be useful too, because you could derive activity-based costing that could be turned into smart contracts and be set as regulations for how a healthcare transaction takes place, where there's no harm, no foul. You have a recognized instance of an anonymized individual trying to perform a healthcare transaction for an activity that both that individual and the provider have agreed upon in their encounter. They're following that action based on a certain CPT code or ICD-10 codes. Those in turn are related to smart contract rules around activity-based costing for those CPT codes, and engage those rules to say, this is the way things will be done. It lays the basis, I think, as I think about it, for a great policy decision to a future to something like value-based care or the SGR model in its most simplistic form right now, to translate SGR into activity-based costing around smart contracts in Ethereum or Hyperledger that would set up as mandatory participation models for blockchain.
Oh, I love that concept. I think I can really see how that could get legs. So speaking of, so we're getting close to the Q&A segment. So just as a heads up to the audience, while we're having the last couple minutes of our dialogue here, please go ahead and capture your questions in the utility, as it'll expedite our flow, if you will, when we get to that segment. The ability to use activity-based costing and map it to particular anticipated episodes of care or well understood protocols for managing certain chronic diseases, and adding a certain level of margin on top of an activity-based cost buildup. I mean, you could create a standard data model that corresponds to standard clinical data models using that.
Correct.
And that could be very powerful. And I can imagine open bidding systems between patients and providers, between payers and providers. That's really interesting. So you mentioned private and public blockchain scenarios. Let's for a second, I know with your background at HIMSS, you did a lot of work on interop, and blockchain does not solve the interop problem, as we all know. But
Yeah.
I would love to get your thoughts on, from the perspective of this institute that you're manifesting and the leadership it will provide to the industry, about private permissioned or consortia-based blockchain networks versus completely public, generally accessible networks, and the way that all of these challenges can be manifested. Any thoughts on
Right.
how you see advocacy in that context? Not a specific technology, but more the general public versus private permissioned uses of distributed ledger technology.
What I've offered offhand and at a high level so far is the concepts that within a health network, you very well may have a private chain with permissioned involvements between select providers and patients, as you would when you have right now a centralized EHR database at any one major regional hospital that has patients at it. And then participation, say, within the broader HIE market, HIE area and market, may be a public permissionless blockchain where, as in the current circumstance, New York General may not trust New York Memorial, but they can participate in the transaction-based consensus sort of permissionless blockchain system, while each of them retain their own private permission blockchain within their own system. And then from a technical standpoint, on-chain and off-chain, healthcare information can be retained off-chain with technical models to be able to point into specific blocks in the chain for both the private and the public chains, as well as APIs and microservices that will integrate chain to chain as necessary too.
So you're envisioning, so one of the things that I come back to again and again is that identity of all actors and all stakeholder participants is something probably best suited to be reused, and hence on a public blockchain, and maybe some aspects of procedural logic in the form of smart contracts, but there's still, so I think what I'm hearing you say is that you're still anticipating private permissioned chains or enclaves where more fine-tuned, detailed interactions are occurring that maybe are bouncing off of public chains at the identity level, or other, forms of verification or authentication and so on. Is that kind of how you're seeing it, or do you see more happening on completely public chains, like in the scenario of price transparency and competitive bidding and free market principles playing out?
So in a permission chain, one of the trade-offs, of course, is anonymization. And I say trade-off in that just using a pure Bitcoin blockchain model, identities for the most part, and I realize technically there's some argument here, but identities for the most part are anonymous. The transactions are anonymous. They're driven by consensus models of trust that build agreement as to how transactions are done. In a permission model, you're going permission blockchains go much closer to the traditional database concept of functionality that we're all aware of, which means either knowing actors or centralized identity. So it becomes a trade-off between permissioned blockchains allowing a certain knowledge of identity between participants, because those participants are trusted, i.e. the patient knows the provider knows the patient, and that's a trusted relationship as culturally understood and understood under HIPAA. How that permissioned chain then participates with a permissionless chain, maybe somewhere at the transaction level itself, or through an API to only share certain information that in turn gets hashed as part of transactions on the public chain. And that those hashed transactions on the public chain may be the source of data for population health management issues, or as we're talking about here, activity-based costing information, or general trends in costs and pricing and the like, but don't necessitate sharing any information with what the permission chains have around patient identity or patient identity, excuse me.
So thank you for that. One other question I'd like to surface is in follow-up to the overview you provided of the history of healthcare banking as a concept, and the graphic medical banking, and the image of convergence of insurtech and fintech that we're looking at now. When we think about recreating wheels across industry segments, payments, for example, as you described, are not only exclusively part of healthcare, and individual consumers and institutions, corporations process payments and acquire goods and services continuously. Do you see part of the transformation of the health transaction being directly attributable to a broader transformation of the way that payments are processed, bigger picture with respect to distributed ledger technology? Maybe you could comment on the convergence there or dependencies there. Love your thoughts on that.
Yeah, I think that you're exactly right. I think that two comments I made earlier in my allusions that there will be changes in how, and continued changes. And I'd use just mobile banking as an example. What I can perform on my phone for financial transactions just in the last 18 to 24 months is more significant than I've done in the last 20 years with the same bank. Transferring money between accounts, the ability to deposit a check, et cetera. And that's without even leveraging anything in the way of blockchain or RPA or AI or some of these other technologies we've talked about. Fintech, through the use of blockchain and others, is changing even how those transactions take place and what a transaction means and the source of funding and the method of recognition of payments between two parties. Cryptocurrency is creating new instruments of value that are disintermediated from traditional fiat currencies that we might know. A healthcare transaction that now could be entirely tokenized, or perhaps money is not even necessarily directly associated with it. As a non-healthcare example, I was given a presentation for a public sector group, and there was a group from a county in Maryland. And we were talking about applying blockchain for alcohol transactions as part of the state-controlled ABC board. And as I began explaining to him the concepts of what kind of transactions could be captured and how it can work, I found myself beginning to elaborate with him on a tokenized method where people could buy into tokens that I called beer coin that would allow you to participate within a state-regulated alcohol control system based on coins you had purchased that allow you transactions that purchase you a certain amount of alcohol at state-based ABC operations. Leverage into that maybe, as with cryptocurrency, the perceived value against the fiat currency of $1 of those coins might go up based on certain times of the year, which would increase your buying power or your ability to exchange out from using those coins and sell them back to dollars again, or be used to buy into other mechanisms that could improve state revenue and state revenue distribution. Taking the alcohol out of it, but still using this concept of creating your own market for transactions around healthcare that disintermediates the dollar as the central instrument of value is, I think, technically possible and leverages all the things we've talked about for tokenization and the concepts of use of distributed ledger technology, and instead just focuses on, and I mentioned DentaCoin. DentaCoin is built this way, and there's a couple other examples you can look into as well, where DentaCoin aims to promote increased dental wellness by the use of coins that are acquired through dental visits, which you can use for dental visits. If you are active in meeting certain dental goals, you earn more coins. If you promote the particular dentist for doing things, they can earn coins, and essentially contributes to a distributed marketplace in and around the participants around new instruments of value that are tied to positive behaviors that don't necessarily include actually exchanging a dollar.
Well, if you can tokenize, if you can create a token strategy that does not convert into a currency, whether it's a fiat currency or a cryptocurrency, you can address the volatility problem that way.
Exactly right. Exactly.
And it's an interesting point that you make, that volatility or token appreciation could be viewed as revenue sources by certain parties. Right. So essentially creating a speculation engine as one value vehicle.
I like that speculation engine, yeah.
It's certainly contrary to the culture of funding healthcare in the current state, but it's an interesting premise. I had been thinking about it more around needing to remove volatility if anything was going to convert to a currency measure, right. Or it would distort every aspect of price and demand curves and all of that. Super interesting. So with your institute, do you imagine yourself leading and forming consortia who will either become actors or participants in proofs of concepts or pilot programs, or draft policy, or be willing to pilot policy interventions in certain geographies or jurisdictions. How do you, let's talk a little bit more about the specific actions that you see the Institute driving forward in its first few years of life. And I ask that because it's a segue to our next poll question. So this is a heads up to the audience that there's a poll question coming about whether you would like to participate in some of the Institute's activities downstream. So I asked that question in that context, Jim.
Absolutely, and I'm going to take the easy way out, which is rather than form my own consortia, from what I have seen on almost a daily basis, is the continued eruption of new consortia across multiple industries, all of which may be addressing different transaction factors. I had a conversation last week with BITA, which is the Blockchain and Trucking Association. It is looking to apply blockchain for trucking specific transactions. And when you think about it, it is supply chain and specific supply chain as well, in terms of loads and driver hours and vehicle use, et cetera, that all lead themselves to blockchain-based transactions. And I reached out to them as the Institute for Healthcare Financial Technology and said very simply, there's a possibility that your consortia is getting into supply chain issues that may manifest themselves as new standards or approaches to things that could be carried over to how healthcare does something. Because more and more of the concepts of transactions, I believe, are merging, and the way the underlying technologies around those things, particularly leveraging blockchain, are assimilating. And there's no reason not to learn lessons in other industries that could be applied here, and vice versa. So speaking to consortia, I can just look to Ethereum and I can look to Hyperledger as two big examples where the technology for the blockchain consortia is being driven, and then consortia such as Sovereign for blockchain-based identity. And then I can look to the Wall Street Blockchain Alliance, or I can look to the blockchain and trucking, or the new Shipcoin model as other sources, and then perhaps NIST with their new standards, or ISO for their standards, and other international as standards-based organizations and as consortia that together, when assimilated or brought together in a patchwork, can lay out the framework for how healthcare transactions can change.
Mm-hmm. It makes complete sense. And so I'm gonna launch the poll and ask you one question while we give everyone a moment to respond to the poll. So my last question is about the Internet of Medical Things, blockchain, and this category. Over the course of our conversation, we've talked about the challenges with transparency, and that in the case of Internet of Medical Things, you could have providers or patients who really didn't want that data being exposed for various reasons, aside from privacy. But let's say because it would change financial access or financial decision making. Maybe you could comment just a little bit on the role you see the Institute playing with respect to policy and advocacy around use of IoMT in this context.
Absolutely, and in matter of fact, I'd give a free plug. The week after next, HIMSS hosts the annual Integrating the Healthcare Enterprise Connect-a-thon, of which we have several technology tracks going on for the first time simultaneously with that, which include both IoT, IoMT, blockchain, devices on fire, and medical health. And that will be a real first opportunity to begin to look at things that are being done, again, in the industrial environment. For instance, IoT is the industrial Internet of Things, and that's looking at blockchain adoption for providing the immutable transaction records for what the IoT devices are recording, with a carryover to that being IoMT, where now you have a medical IoT or a medical device or telemetry information that can be captured in a blockchain. So as we look into how a distributed ledger enables IoT for other industrial applications, I believe it becomes a point of policy advocacy for healthcare to be able to adopt IoT and that use from a medical use, substantiated by or supported through the use of blockchain for distributed ledger and recording those transactions information.
Yeah, it's remarkable the benefit of cross pollination across, the intra-industrial cross pollination with all of that. Would you mind? I have a feeling that I'm not alone in that I would like to have you repeat what you described about what HIMSS is launching next week, just because I'm not sure everybody heard it, and I know I didn't capture all of it. And last reminder, please answer the poll. We've got 68% of the audience has responded. What are your, would you mind repeating that in terms of what exactly HIMSS is launching next week for anyone who missed that?
Sure. It is technically called IHE-USA, which is Integrating the Healthcare Enterprise. It is an international healthcare standards development organization. And every year in January, in the Garden Spot of Cleveland in January, we conduct a week-long what's called a Connect-a-thon. It's an opportunity for health IT vendors to test their adoption of healthcare standards into their health IT systems. What we're doing this first time, this inaugural event, will be to include a day of presentations and discussions along certain other tracks that are IoT and blockchain and healthcare and mHealth as a way of introducing these new emerging technologies, especially blockchain, of which I'm the technical project manager for, to traditional health IT vendors in ways that we can substantiate new ways to participate together.
Oh my goodness, that's so exciting. Thank you for reiterating that. I know I had not been aware of that initiative, and it sounds extremely compelling. So thank you, Jim. So here are our last poll results, and you'll be well. You can see this now because you're back online. What are your thoughts about the results?
I'm very excited. I'm excited that people would be willing to spend the time with me on a Wednesday evening to be engaged in this discussion between the two of us, and would like to participate further. And I welcome their participation, certainly.
That's wonderful. Thank you for being such a great audience, and for so many of you being curious and interested in participating in the Institute's initiatives. So I think we're ready to start our question and answer session. So this is where it sounds like a radio show. So our first questioner is Tim Lackey. So I'm going to give you a heads up, and I'm taking you off of audio in just a moment. And Tim, if you want to briefly introduce yourself and then reiterate your very interesting question regarding, I think, convergence, inter-industry convergence. How are you, Tim? Can you hear us?
Yeah, I can hear you. Can you hear me?
Yep, sure can.
I can hear you loud and clear, Tim.
Cool. I guess because I deal with a lot of different blockchain technologies in different industries, obviously the supply chain management, fintech and healthcare. I'm not an expert in healthcare by any means as far as that, but as far as IoT and radio communications, very, very, very deep. But blockchain technology is being used and developed in all these different verticals. And what it seems to me is that when healthcare, your circles here of healthcare, insurance, fintech, when you look at different blockchains, they have different use cases and they accomplish great things in their own way. But sometimes to be an expert from a healthcare side, looking at a communication side, you're looking outside of your box. And what you're trying to do is trying to build it within your box. So as a consortium or a group of intellects trying to build this within your network, do you feel that you have to maintain that within your network, or do you build a digital demarc, or you set a wall and say, this is my data, it comes to this place on these blockchains? And if a fintech wants to go to it, it goes to that digital demarc. So it's more of a layering system. And maybe can you go a little deeper as far as how you look at that in the future?
I would love to go deeper, but I'm afraid I don't have an immediate answer. But what you've brought up is an excellent example of some of the challenges, either intra or inter-industry of that sort of integration. First of all, if you were trying to do a chain-to-chain sort of integration between respective industries, or two industries on separate chains that are trying to integrate information. And I think it comes down to obviously business agreements in advance and determining the process flows. What are the essential elements of information or data to be included, and then what architecturally is the right way to go by capturing that. And we talk blockchain. We could talk centralized databases. We can talk APIs and microservices. In some fashion, all of those are technically possible to capture the information that is needed between participating organizations, but it's driven with rules. I would offer closest example perhaps is within healthcare around HIEs, which is again all within an industry, but just establishing the rules by which participants share healthcare information on a very disparate basis are built around long and extensive rule developing efforts. And those, it was almost easier to develop the technology to support it than develop the rules for agreement. So I think that's the best answer I could probably give you now, but it's certainly an area that has to continue exploration.
Yeah, I mean, my forte is looking at the self-sovereign identity across all these layers. So, if my financial rail has to go across healthcare, real estate, fintech, my customer ID, at a vendor. I mean, so this is where I see the layering falling, in a vertical pathway, even though healthcare sits across all of them and you have a lot of those elements. It's just, how does my self-sovereign data transpire across all of these consortiums that are being built on blockchain? So that's really my concern.
That's a great question, and even above and beyond blockchain, healthcare, like many industries, suffers from the ability to, or suffers from a lack of an information model. So within HIMSS and within Health IT, there's been a lot of time spent around things like HL7 standards and others, and XML. All of that is capable of taking your healthcare information and breaking it down into elements, and we can even set policy objectives around those elements, so that you can agree, I want to share this, and this with this provider, and this, and this with this provider, but the two providers don't get to see the same thing. That is technically speaking possible, but it requires policy decisions that no one bothers to make, which is why you still see institutions faxing forms back and forth to one another. So just coming up with that information model first and foremost, I think, will help guide some of those concerns about self-sovereignty. But that's more of a cultural change than a technical change.
So we'll have atomic data healthcare swaps.
Exactly. That's exactly right. Well,
all right. Okay, I'm cool. Thanks, man.
Thanks, Tim. We appreciate it. Putting you back on mute. All right, folks. So this is an opportunity. So we have an opportunity to take maybe one or two more questions. Would love to get some more questions out here. In the meantime, so I'll give you a moment to get a couple of questions typed in. And Jim, one of the elements of this convergence across industries is this question of efficiency as we seek to revolutionize characteristics that span multiple industries. And this notion that we're better off preventing wholesale recreation of wheels across industries. And you'd mentioned earlier that you see your institute being part of driving bi-directional feeds of best practices, architectures, utilization of common infrastructure. So both learning from healthcare and bringing those innovations out to other industries, and preventing healthcare from recreating wheels that have been solved in other industries. Any elaboration on maybe some examples or some preliminary thoughts on I know you've commented quite a bit on the things that have been advanced in fintech that are completely still quite backward in healthcare. Any ideas on what healthcare might be able to contribute to the rest of the industrial world?
That's a great question, and I don't want to just say no because I can't offer something. Can you still hear me?
Yeah.
Okay.
Still hear
Okay.
you.
I'm sorry. Yeah, I just lost the internet connection, which is perfect now since we're down the last couple of questions, but I'm still with you on the phone. Yeah. So I think some challenges that you have in other industries of healthcare may address. Privacy and security really isn't that bad. I spend quite a bit of time there, and at least healthcare is cognizant of it. There are some newer technologies and applications of technologies around privacy that healthcare could offer to other industries. So that's one thing, and that's above and beyond a blockchain method. But I hate to be disparaging, but I'm hard pressed beyond that to come up with things that healthcare could contribute to other industries more so than other industries could contribute to healthcare. And unfortunately, I think a lot of that just stems from the fact that so many other industries or so many other industries are driven by an understandable financial motivation that translates into metrics and delivery that are competitive within a marketplace that healthcare just doesn't have.
Yeah, it's interesting. It's not as if we would advocate everyone moving to large-scale EDI processing for payments, for example. Here's what you do.
The way of the future.
Yeah, it's brilliant. And fax. Everything should be run using fax. It would be fantastic if you ran all of your business processes via electronic fax. So any closing remarks? So we're hitting our time window here. So closing remarks coming out of this event and discussion, Jim.
I would say I thank everyone for participating tonight. It's great to see that level of potential interest, and I look forward to working with you in the future to move our objectives along. Don't hesitate to contact other people and tell them about my crazy idea. You're welcome to reach out to me on LinkedIn, and we can have further discussions there, and then I can also contact you directly.
Well, thank you, Jim. Really appreciate you being here tonight. I know I'm extremely excited about the positive contributions your institute is going to make over time, and look forward to supporting it in any way I'm able to do so. And it's been a pleasure communicating with you about it this evening. So some closing remarks. Thank you to our active participants for your engagement. Our next event in this webinar series is January 16th. Our guest speaker will be David Holding from Intel, who's their Director of Data Privacy and Security and is responsible for a cybersecurity framework in the health and life sciences that is led by Intel. So that's going to be the topic for the 16th. Looking forward to it. All of you will receive your reminders and so on ahead of the event. And thank you. And Jim, hopefully we can have you back on in the future to give us some updates on the blockchain related initiatives at the Institute.
Absolutely. And two shouts out, first of all, to you, Heather, for this outstanding event, outstanding organization, what you're doing for advancing this. I think it's wonderful, and I'm very proud to have been part of it and humbled. And then David works with me on my healthcare blockchain working group for HIMSS and will be an outstanding speaker. So I highly recommend everybody to join on the 16th as well.
Thank you, Jim. I appreciate that on both points. And thanks, everyone, and have a wonderful evening and Happy New Year, January 3rd, 2018. Good night.
Good night.